Okay, hello, welcome to my YouTube channel. My name is Gabby. I am going to do another informal study with me video for the CVICU. It's gonna be very off the cuff. I'm gonna have some Christmas music on in the background, so hopefully that's not annoying. And I will apologize again that I might have commercials pop up, so I apologize in advance. Today's video is going to be on hemodynamic monitoring and mechanical ventilation and arterial gas monitoring. So let's jump into it. The first thing that I want to learn about with hemodynamic monitoring is central venous pressure. The prettiest sight to see is the holly that will be on your own. And I'm gonna post these notes up on the screen once I'm done making them. Okay, central venous pressure can be measured by transducing an interjugular IJ or subclavian line. I know this. The pressure reflects the pressure in the IJ or the left atria and is largely reflection of preload or volume status. Everywhere you go, there's a tree in the Grand Hotel, one in the park as well. It's the sturdy kind that doesn't mind the snow. It's beginning to look a lot like Christmas. Soon the bells will start, and the thing that will make them ring is the carol that you sing right within your heart. It's beginning to look a lot like Christmas. Toys in every store, but the prettiest sight to see is the holly that will be on your own front door. Sure, it's Christmas. Okay. It's important to note that, similar to an arterial line, the CVP waveforms reflect mechanical changes in the vasculature. During asystole, the pressure increases in the atrium and reflects positive pressure toward the IJ.
Brought to you by Sephora. Click or tap the banner to listen now. Did you know you may be able to get Nexplanon?
During atrial systole. Tricuspid valves close, a small notch can be seen. Finally, as the atria fills, again during atrial diastole, another influx of pressure can be noted. Because the pressure transduces from the venous vasculature, the pressure gradients between systole and diastole are much smaller. For this reason, a mean pressure gradient is considered accurate. Interesting.
You better watch out, you better not cry, you better not pout, I am telling you why. Santa Claus is coming to town. He's making a list, he's checking it twice. He's gonna find out who's naughty or nice. Santa Claus is coming to town. He sees you when you're sleeping, and he knows when you're awake. He knows if you've been bad or good, so be good for goodness sake. You better watch out, you better not cry, you better not pout, I am telling you why. 'Cause Santa Claus is coming.
Normal CVP ranges from 2 to 8. As with all transduced pressures, accuracy is dependent upon the nurse leveling the transducer to the phlebostatic axis and zeroing the pressure to atmosphere.
Sees you when you're sleeping, and he knows when you're awake, and he knows if you've been bad or good, so be good for goodness sake. You better watch out, you better not cry, you better not pout, I'm telling you why. Santa Claus is coming to town. You better watch out, you better not cry, you better not pout, I'm telling you why. Santa Claus is coming, I'm a big fat man.
Pulmonary artery catheters. Pulmonary artery PA catheters are catheters inserted through the IJ and advanced so the distal tip rests in the pulmonary artery.
Merry Christmas, ladies.
Merry Christmas, Mr. Buble.
Are you ready to sing a little jingle bell? Jingle bells, jingle all the way. Oh, what fun it is to ride in a one-horse open sleigh.
Various ports open along the trajectory of the PA catheter, allowing clinicians to transduce data from multiple places in the heart. PA catheters continuously transduce a CVP from the right atrium via a proximal port, as well as pressures from the pulmonary artery via a distal port. Because the pulmonary arteries are pulmonary circulation, these pressures are much lower than the systemic pressures.
Dashing through the snow in
pressure. Elevated PA pressures may indicate essential pulmonary hypertension, embolus, or other pathology increasing the vascular resistance in the lung beds. PA catheters are floated into the pulmonary artery by inflating a balloon on the tip of the catheter that acts as sail, pulling the catheter further into the heart. As the catheter is initially inserted, the nurse should notice a CVP waveform from the distal PA catheter port. Cardiac output and index. PA catheters also always allow for direct measurement of cardiac output. While there are many methods to calculate cardiac output, CVICU most commonly uses thermodilution PA catheters. Using this method, 10 mL of room temperature normal saline is rapidly infused through the proximal CVP port of the catheter. The distal end of the catheter then measures the change in temperature and uses this information to calculate the rate of blood flow through the heart in 1 minute. The average cardiac output ranges from 4 to 8. Depending on body size and physiological demands. To simplify, the evaluation of this information, cardiac output, can be normalized for patient body surface area. This number, the cardiac index, normally ranges from 2.5 to 4. The CVICU, a CI less than 2, is reportable value to the provider team. A decrease in cardiac output is likely an indication of decreased preload volume, increased afterload, or decreased contractility. One of those three. Love it. Patients in moderate to severe septic shock may exhibit dramatic decreases in afterload that subsequently increase the total amount of cardiac output. Systemic and pulmonary vascular resistance. With the addition of cardiac output, systemic and pulmonary vascular resistance can be calculated. Systemic vascular resistance, SVR, uses the mean arterial pressure, MAP, CVP, and cardiac output, CO, to estimate the total resistance to ejection during systole. Therefore, the CVR is direct reflection of systemic afterload. This value uniquely reflects the afterload experienced by the right side of the heart during systole. Normal SVR is 800 to 1400. Normal PVRs 50 to 250. Both SVR and PVR provide tremendous value in differing types of heart failure, types of shocks, and determining the course of treatment in mixed shock. Mechanical ventilation. Patients may need to be mechanically ventilated for a variety of reasons, including but not limited to inability to protect their own airway, respiratory distress or arrest, sedation, or severe oxygenation issues. At Vanderbilt, the ICU fellow attending or respiratory therapists, RT, are the only personnel allowed by policy to make ventilator changes. Nonetheless, nursing staff must maintain a basic knowledge of ventilator modalities, anticipate ventilator changes related to patient's clinical picture, and troubleshoot common alarms. In a healthy individual, respiratory rate and depth are determined by autonomic nervous systems. A negative intrathoracic pressure drives inhalation as the diaphragm lowers with each breath. In the mechanical ventilated patient, however, respiratory rate and depth care controlled manually. Respiration is instead driven by positive pressure via the ventilator. Ventilator modalities are named by the specific component of ventilation manipulated in each mode. Classically, volume control or pressure control modes Ventilator parameters are reviewed in box 2.1. Ventilator modes can be compared in box 2.2. Okay, preceptor pearls. A PA catheter insertion wedge pressure should not only be attained in medical cardiology patients with a physician order due to the risk of PA rupture and infrequencies of use. Our standards of care stipulate that only physicians or advanced practice providers wedge patients. Oh, interesting. I think that was for the other part, not for our ventilation part. Where's box 2.1? 2.1, FiO2, fraction of inspired oxygen, the amount of oxygen delivered to the patient. P, positive end expiratory pressure, the amount of positive pressure continuously delivered to the patient to keep the alveoli open. PIP, peak inspiratory pressure, the maximum amount of pressure needed to inflate the desired volume of air. PEEP and PC settings equal PIP. Respiratory rate, the number of respirations in 1 minute. Duh. Tidal volume, the volume of air instilled with each respiration. Inspiratory volume should equal expiratory volume. Interesting. Minute ventilation, tidal volume times respiratory rate, the total amount of air ventilated in 1 minute measured in liters per minute. Assist control ventilation. In an assist control AC ventilation, a set number of breaths are delivered in a given amount of time. This modality can be further specified as volume control or pressure control. In volume control ventilation, the tidal volume of each respiration is set, but the pressure required to deliver this volume will vary with each breath. By contrast, pressure control ventilation sets the amount of positive pressure that will be used to deliver each breath, allowing the volume to deliver in both modalities. Respiratory rate, positive and expiratory pressure, PEEP, and amount of oxygen, FiO2 delivered are set. If the patient attempts to breathe in between these breaths, the ventilator will assist the patient with these breaths to deliver the designated volume or pressure. This may unintentionally cause a patient to hyperventilate, and nurses should be careful to note the difference between a set number of ventilator breaths and the delivered number of ventilator breaths. Interesting. Synchronized intermittent mandatory ventilation. In a synchronized intermittent mandatory ventilation, SIMV, the ventilator also delivers a set number of breaths during a given period of time using pressure or volume control. However, in this modality, the patient may breathe spontaneously between the ventilator mandated breaths. Importantly, the ventilator will attempt to synchronize mandatory breaths with spontaneous patient effort, making this mode of ventilation more comfortable for the patient and decreasing the risk of hyperventilation. This mode of ventilation requires more patient effort than assist control ventilation. The CVICU most commonly uses SIMV with a dual control mode of ventilation known as pressure regulated volume control, PRVC. In PRVC, the volume for each respiration is set, but the pressure required to deliver this volume is limited. Pressure support PS mode of ventilation is considered to be weaning mode of ventilation. In PS, the rate, tidal volume, and inspiratory rate are not set, requiring the patient to initiate their own breaths and maintain their own respiratory rate. Alarms and troubleshooting. Common ventilator alarms include PAW high respiratory rate, and regulation pressure limited. An airway pressure high, PAW high alarm indicates increased airway pressure caused by a blockage in the ventilator circuit. Common causes include patient coughing or biting the ETT tube, patient needing to be suctioned, the heat moisture exchanger, HME, needing to be changed, or crimped tubing. Nurses should assess the patient and ventilator tubing to address this alarm, suctioning the patient as needed. If the HME appears saturated, nurses may change the HME on ventilator circuit. on the ventilator circuit. High respiratory rate alarms indicate that the respiratory rate has exceeded the alarm limit. This may be caused by pain or anxiety requiring increased sedation or by patient decompensation. Nurses should address the root cause of the increased respiratory rate as warranted by the patient picture. Nurses should also assess whether the respiratory rate alarm is appropriate for the patient and notify respiratory if the alarm limits should be recognized. Ventilator modes. SIMV definition delivers set number of breaths at a set volume per minute synchronized to go with the patient breathing pattern. Gives more control. Synchronized intermittent mandatory ventilation. Pressure regulated volume control. CPAP and pressure support. Volume control, also known as assist control. Bivent, VDR, volumetric diffuse respirator. Okay, we're gonna go back to the synchronized intermittent mandatory ventilation. When used, most post-op patients are on the PRVC, allows the patient to do some of the work, and weaning mode. Key clinical points. Patients can take own breaths, but set tidal volumes is not delivered with those breaths. Pressure support is used for those breaths. PRVC, pressure regulated volume control. Control mode of ventilation with a set rate, set tidal volume, and set PEEP. The ventilator regulates how much pressure control needed by the set tidal volume. Does not aid spontaneous breaths. Used in patients with less compliant lungs, such as ARDS and post-op patients. Combined with SIMV alternate modes. By itself, PRVC is not a weaning mode. Control is taken back over by the ventilator so the patient cannot initiate own breaths as easily, thus can be anxiety-producing mode. CPAP and pressure support, continuous positive airway pressure, positive pressure exerted on lungs, constant pressure through inspiratory and expiratory cycle, pressure support added to help aid in keeping lungs open during inspiration, used before extubation to see if patient can breathe on own. Patient creates own tidal volume and rate. Patients must be able to spontaneously breathe. Volume control, also known as assist control. Control ventilation with set rate and set tidal volumes. Patients can initiate a breath, and ventilators will give a breath. Used for patients with low spontaneous tidal volumes, not weaning mode. Can decrease cardiac output, does not have pressure support. Bivent, inverse expiratory and inspiratory rate. Prolonged inspiratory time with short expiratory time. ARDS, decreased SaO2, and increased peak pressures, unable to vent. Very uncomfortable. Ensures that there's adequate sedation. VDR, volume diffuse respiratory. High frequency ventilators, high rate with low tidal volumes. Oxygenation occurs through diffusion, internal percussion. ARDS, low SA2 with increased PIP, unable to vent tidal in other modes. A regulation pressure limited alarms occur in PRVC modes when the pipe becomes too high to allow the ventilator to deliver the set tidal volume. This may indicate the patient's lung compliance is decompensating or that the patient is fighting the ventilator. Nurses should assess their patient to determine whether the patient appears to be in pain and assert whether increased sedation is warranted. If no discernible cause can be determined, the nurse should notify respiratory and the care team. Ventilator weaning, spontaneous awakening trials, and spontaneous breath trials should be conducted daily on ventilated patients in collaboration with interdisciplinary care teams. Prior to conducting an SAT, the nurse should complete the SAT safely screen box 2.3 to conduct SAT. To conduct SAT, The nurse should pause sedation and analgesic infusions until an adequate neurological exam can be obtained. If the patient is able to follow commands with sedation weaning, then the nurse should conduct an SBT safety screen and contact the care team for approval to begin an SBT. If the team approves to patient to participate in an SBT, the RT will place the ventilator into pressure support on minimal ventilator settings. However, if the patient experiences anxiety, agitation, or pain that cannot be managed by PRN medication, respiratory distress, or any acute cardiac rhythm changes, the nurse should resume continuous sedation and contact the RT to place the patient back on full ventilator support. In the CVICU, it's our goal to extubate patients within 6 hours of cardiac surgery unless their clinical exam warrants otherwise. Once the patient achieves hemodynamic stability after surgery, the nurse should collaborate with cardiac surgery team to determine when it will be appropriate to wean sedation for an SAT. Box 2.3, acid-base imbalance. SAT safety screen, no active seizure, no alcohol withdrawal, normal intracranial pressure, no MI, no agitation, no paralytics. SBT safety screen, no agitation, oxygen saturation above 88%, FiO2 below 50%, PEEP below 7.5, no vasopressor use, inspiratory efforts. Arterial blood gas monitoring. Arterial blood gas, ABGs, measure the content of oxygen, PO2, and CO2 in dissolved inpatient blood. Values generated through an ABG sample will offer insight into a patient's acid-base balance, determine the source of imbalance, and guide treatment changes in critically ill patients. To maintain a normal cellular metabolism, a narrow pH range of 7.35 to 7.45 must be maintained. A pH of less than 7.3 is considered acidotic, while greater than 7.4 is considered alkalotic. Under normal circumstances, the human body maintains hemostasis by regulating HCO3 negative through the kidneys and CO2 via the lungs. If the primary abnormality in the ABG is in the PaCO2, then the disturbance is considered respiratory in nature. If the primary abnormality in the ABG is HCO3 negative, then disturbance is considered metabolic in nature. To interpret ABG, the nurse should first determine whether the pH is normal, acidotic, or alkalotic. Right. The nurse should then determine whether the PaCO2 and HC3 negative are within normal ranges. Respiratory acidosis and alkalosis. Respiratory acidosis is caused by any condition that includes hypoventilation, thus evaluating a patient's CO2. This may include primary lung disease, sedation impeding a patient's intrinsic respiratory drive, brain injuries, neuromuscular disorder, pneumothorax, and trauma impeding breathing mechanisms, or incorrect ventilator settings. Conversely, respiratory alkalosis is caused by any condition that induces hyperventilation such as hypoxemia, sepsis, or even anxiety. In mechanically ventilated patients, nurses can expect providers to increase or decrease a patient's minute ventilation by manipulating tidal volume and respiratory rate to mitigate an acidosis or alkalosis of respiratory origin. An increase in minute ventilation will decrease pH. A decrease in minute ventilation will increase pH. Metabolic acidosis and alkalosis. A decrease in HCO3 causes metabolic acidosis. Causes most commonly include diabetic ketoacidosis, lactic acidosis, and renal failure. Metabolic alkalosis is characterized by an increase in HCO3. I think this is just levels, and is most commonly caused by diuresing, vomiting, or potassium deficiency. Notably, massive transfusions may cause metabolic alkalosis due to citrate in the preserved blood product. Compensation. Patients may partially or completely compensate for acidosis abnormalities. Patients who have compensated will demonstrate a normal or near normal acid-base balance. To compensate for respiratory abnormalities, the kidneys will either excrete or reabsorb additional HCO3. Compensation for respiratory acidosis, therefore, is characterized by a normal or near normal pH with abnormally increased HCO3 and CO2. Compensation for respiratory alkalosis is characterized by a normal or near normal pH with decreased HCO3 and CO2. Renal compensation for respiratory abnormalities may take several days. To compensate for metabolic abnormalities, a patient may regulate breathing to retain or remove CO2. For metabolic acidosis, a patient may increase the respiratory rate and depth to decrease the amount of CO2 dissolved in the blood. Conversely, a patient with metabolic alkalosis may decrease the respiratory rate and depth to retain CO2. Respiratory compensation occurs faster than metabolic compensation, taking only a few hours to compensate for abnormalities. Apply your knowledge, clinical case study. Use the knowledge gained in this chapter and following scenario to answer the questions below. When you're ready, you can check page 69 for the answers. You are caring for a patient admitted to the CVICU yesterday for cardiogenic shock. The patient is intubated on the following ventilator settings: SIMV, PRVC, FiO2 60, respiratory rate of 12, tidal volume of 450, and a PEEP of 8. The patient has a PA catheter inserted to the depth of 48 centimeters with the following data populated on the Philips monitor: CVP of 18, so we've got an increased CVP. A PA of 45/25, okay, fairly certain, not 100% sure that the diastolic PA is increased though, at the very least. And a wedge pressure of 24. Based on the data presented, you assess the patient is in, I think it says the options are volume overload, ureic volume, volume depleted. I think it's volume overload because the CVP is high. We're gonna go to A. After completing your 8 a.m. thermodilution cardiac output measurement, you note that the patient's cardiac index is 1.7, so you've got a low CI. Based on this information, your first action is to continue to monitor the patient. The index is expected for a patient in shock. Did they say this patient was in shock? Oh, he was admitted yesterday for cardiogenic shock, but we should have been doing things to fix that by today. Notify the provider because this cardiac index is below threshold for reportable values. I would agree with B so far, but let's see what C has to say. Review the patient's PVR and SVR to evaluate the type of heart failure and the patient exhibits. I'm gonna go with B. I'm gonna tell the provider about that because we read earlier today that said that any cardiac index is below 2, no matter what, should be reported to the provider, and that's a cardiac index of 1.7. You send an AVG and note the following values: pH 7.3, PO2 96, and PaCO2 50, and HCO3 24. Based on this information, you expect the provider to make what ventilator changes? Okay, increase the ventilation rate to increase the minute volume. Decrease the ventilation rate to decrease the minute volume. Increase the ventilation rate to decrease the minute volume. Okay, let's look at these again. You set an AVG and you find that our pH is 7.3, which normal is 0.25 to 0.35, right? So I think the pH is normal, but I'll need to double check this. The PO2 is good, 96% is wonderful oxygen level. PaCO2 50, so we have a high CO2 I don't remember what normal HCO3 negative is. Let's check. Okay, no, normal is 7.35 to 7.45. So we have a acidotic pH level. We have a normal PO2. Our CO2 level our CO2 level is high. And then we have a normal. I think they're gonna want us to breathe more. Increase the ventilation rate to increase the minute volume. I'm gonna go with A, but that was definitely the hardest question thus far. See what that said? Let's see, let's go to page 69. Okay. Okay, we got that one right, we got that. Okay, we got all three right. I'll read the rationale. The CVP normal is 2 to 8, a CVP of 18 is elevated, thus representing volume overload. Knew that. B. Although the index is 1.7 may be normal for this patient, cardiogenic shock, this should be immediately reported to the provider because it's below the threshold for reportable values and requires treatment. While you may evaluate the patient's PVR and SVR, this is not the most urgent action. Question 3, the answer was A, like I thought. The patient is exhibiting respiratory acidosis. Got that. To relieve this condition, the minute ventilation should be increased by increasing respiratory rate. Makes sense to me. Now we're going on chapter 3, which maybe I will make another video later about chapter 3, which is going to be on critical care pharmacology. Sorry if this video was kind of boring. I feel like it's a lot of me just talking at you. But we learned some things today. Yeah, thank you. Catch me on my next video.